10 minutes. I got the handouts there. I'm Shawn. I'm one of two. I'm in the process of training when she can start with me full-time, hopefully in a week. A second device nurse. We follow hospital-wide about 1,800 patients. So needless to say, I'm drowning. But anyway, so that's why you don't see me a lot. Ideally, when I started this job 8 years ago, I was going to be able to see all patients that come through the OR with a device. There's no way possible because I see patients in clinic 5 days a week, plus I follow all of those patients remotely, so I'm usually averaging about 50 to 100 patients a day.
So don't cut you out if we don't see your name in the
right, that means I wasn't notified ahead of time. So I'm going to do a brief, just real quick synopsis, then I've got a few things to show you. I'm hoping if I hit enter, is that one?
If you had the, yeah, right here.
That one. Just so you know, a lot of times when you see documentation, you'll see ICDs, pacemakers, implantable loop recorders, or called links. You'll see those labeled different ways. Some of the documentation from the Heart Rhythm Society and the Anesthesia Association labels them CIEDs, but that just encompasses all of those. This by no means is a set policy for NCG or Augusta University. I'm hoping sometime in the near future that anesthesia and EP can get together and have a policy for that. I've worked on it for 8 years and it's still not there. So eventually we'll get there. Real quick, just so you know what we're talking about, there are pacemakers, defibrillators, and implantable loop recorders up there, and I've got demos for people to see if you want their hands on them. I've got pacemakers, defibrillators, lead pacemakers, and the leads. And that just shows you there. The pacemakers are really small now compared to what they were 20 years ago. And you can kind of see the difference. The defibs are a little bit bigger because they've got more work to do. And just the difference there. A new pacemaker sometime that you will see is that one on the left, which is called a micra. It's actually a leadless pacemaker, looks like a little bullet. Gets they go up femoral, go into the ventricle and just drop it in there, and then the tines take over fixing it. And then the one that looks painful. This is the sub-Q ICD. If you ever have a patient that has a sub-Q, it's going to be on their left side. If they're really thin, it looks like a hockey puck sticking out on them. I don't know how it's not painful, but so far patients say it's not. And then instead of having a lead actually going through the venous system into the heart, it's actually tunneled under the skin, and if they're thin enough, you can see it. It kind of encompasses the heart, and that's how they defibrillate through that one. They can't pace with that. That's up and coming. But I'll put this in there just so you wouldn't see the Heart Rhythm Society and American Society of Anesthesiologists got together. This is dated 2011, 2013 is the last time they really did anything with this. It's hard for me as the nurse that gets the data to say for a single, I can't say for all pacemakers you need to do this, this, and this, or for all defibrillators you need to do this and this, because it depends on the type of surgery they're having, where it's at, where their device is, if they're pacemaker dependent or not. All of that plays into it. And then I have strict criteria for what I want to see on a patient before I will make a recommendation. So sometimes you'll see a note from me and sometimes you don't. It's just according to if I can get the data. For preoperative management, here right now, if they come in to have surgery and they've gone through the pre-op anesthesia clinic, they know they've got a device. They will send me a paper requisition plus a fax requisition plus an email, and I will do a note. As I am by myself right now, a lot of times my note doesn't get in there until the night before the surgery. I notify a rep if the device needs to be programmed, and we'll talk about that in just a minute. But I take care of all of that as far as making sure our recommendations are in there. Hopefully they're followed. There have been instances where they're not, but that's not me. So if I have done a note on a patient, or if you need to know anything about their device and they're followed here, if you go under clinical notes, cardiology diagnostics, you'll see a tab that says pacemaker analysis. That is any type device that's followed, whether it's ICD, a loop recorder that's implanted, pacemaker, you will see some sort of note there for me. If it's for a particular surgery, you will see it like it is there, ICD management for procedure, and I'll put the date, or pacemaker management, and I'll put the date. But that's where you'll see that, and that's pretty much it as far as pre-op, what you'll see. For the intraoperative management, the way I make my decision is I look for the last date the device was interrogated and make sure all the data's good and functioning normally. I have to know what type of device, the surgery that's being performed, the location of the device compared to the surgery site, and then the biggest thing is whether or not they're pacemaker dependent. Plus, we just know that their heart rate will drop once they're sedated. The three options that you will see, I will say place a magnet over it. For pacemakers, when you put a magnet on top of it, it makes it pace no matter what it sees. Pacemakers are basically a little timer for the heart. It looks for, in milliseconds, a certain beat that we have set. If it doesn't see that, then it paces. When we put a magnet on it, it's gonna pace at the set beat. It's according to the manufacturer. Most of the ones that you all will see, if a magnet's over it, it's either gonna pace at 85 or 100. There are some other vendors like Biotronic and Soaring that we don't see a whole lot of. They're a little bit different. St. Jude Medical, which is now Abbott, Medtronic's the biggest that you'll see, and then Boston Scientific. Those are all either 198.6 or 85, and it's just according to which vendor. For defibrillators, the magnet will make the device blind to any electrical activity, because the defibrillator is looking for electrical activity that it thinks is too fast to get ready to shock. So when you put a magnet over it, it's gonna say, okay, I don't need to pay attention because electric cautery, just some of the, I think they're better now, but one of the OR rooms here, just plugging in something in the room would make the defibrillator pick up noise. So it just makes it not see any of the noise and makes it blind, so that way it won't defibrillate. The trick with that is you have to keep the magnet on top of it. So I usually will recommend to tape it in place. And I mean, just from my 20 years of doing devices, I tape it. I mean, I tape it hard so that it's not going anywhere. Putting a magnet on top of an ICD does not affect the pacing. So if I get requests for management and a patient is pacemaker dependent, then I'm gonna ask the rep to program the device. And then if a patient is pacemaker dependent, or if they've got an ICD, they're having any kind of surgery from, there's so many different recommendations for this, and I can't even get my 4 docs to agree on it. But my rule of thumb is mid-thigh up to the head, they're gonna get programmed. Just because I've had too many instances where patients have almost gotten shocked or have gotten shocked because of the electrical activity that it can see. The newer devices have gotten a little bit better, so we're not quite as strict, but for the general rule, that's what we'll do. If somebody is pacemaker dependent, they've got a pacemaker, then I'm gonna recommend that the rep come in and program the device, and they'll need to be reprogrammed post-procedural, and we'll go over that in a minute. For ICDs, there's 2 things that they have to program. If I need them to pace no matter what because they're pacemaker dependent, then they're gonna have to program the pacemaker portion of the device to asynchronous, as well as they will turn therapies off so that the device, and detection off, so that the device cannot deliver therapy. That being said, a defibrillator patient that has their device programmed needs to be hooked up to an external defibrillator at all times, because the device will not do a thing to help. If they have a magnet on, you can take the magnet off and give it a second, it'll pick up detect and shock, or pace if it needs to. But most of the time, we just recommend, and you'll see in my notes, I have them hooked up to an external defibrillator. We've run into times where that didn't happen, but the reps are really good about following up, making sure they won't turn them off without that. Some procedures are pretty benign. To be on the safe side for pacemakers, I'll say just have a magnet in the room. Or if it's a defibrillator and it's pretty, I mean, you know, they're doing a knee or something like that, I'll say to have a magnet in the room just in case something changes with what they're doing. And all of my notes are signed by one of my electrophysiologists, so if I have a question, I'll ask them, you know, what do you think, what do you need to do? Postoperative is probably the biggest portion for what you all will see. If a magnet was applied during the procedure, taking the magnet off, it goes right back to functioning the way it was when they walked in the door. You don't have to do a thing. There's no need for an interrogation. There's no need for evaluation of the device. It's going to work fine. If the device was programmed, when they come out to you all, they will need to still be hooked up to the external defibrillator until the device is programmed back on. Pacemakers, not so much, just because, I mean, they don't need the external, but they'll still need to be programmed back to their pre-procedural settings to get back to what they were when they walked in. Most of the time, if a rep's coming in to program, they'll go ahead and run a device check as well.
Is that done in PACU or phase 2 or both?
I think PACU, but I can't swear to that because the reps have not told me.
I had never had one come up, that's why I'm asking.
They may do it.
How
I
is that?
don't do them because they, I get the reps too.
How is it communicated to the PACU
Hello?
setting? Is it just by anesthesia, word of mouth? Like how, when they roll out, do we know for sure?
They do have a sticker, and
They have
it'll
a
tell
sticker.
you, it should
Okay.
have a sticker on it if it
I
needs
thought there was.
interrogation, but there is a lot of confusion if the magnet's used, like some of our anesthesia people, go in and call the rep, and I'm like, well, I used to work in the cath lab, but I'm like, why?
Yeah,
But I like that
with-
you're putting the note, now I know where to find it to back what I'm saying.
Yeah, if
We
there's,
usually print it if we do pre-op, and we know we print it and put it in the chart too.
Yeah.
and then, really and truthfully, that's it. I mean, that's all there is to it. Pacemakers, defibrillators, implantable loops, you don't have to do a thing for those. But, I mean, it's not, magnet is the easiest route because you don't have to do a thing. You just put it on there, you take it back off, and you're done. Programming, it's a little bit more tricky because I have to get a rep to come in to do it, which most of them are close, so it's fine. But I do try to give them a couple of days heads up if I see that I'm gonna be doing that. The other problem is patients that come in that don't go through pre-op anesthesia. I don't know anything about those, so you won't see a note from me. But any questions at all, if you ever need anything, I've got my card here, my email, of course, and then office number. If you run into trouble with a device, post-operatively, I can't come check it without EP being consulted. So, and they'll usually get the fellow to come down. And that's it. Thank you guys.
Thank you.
Thank you.